Hey, Alvin. Welcome to the Healthcare Intelligence Podcast. Very excited to have you here. Alvin currently is the Gills AI professor at Johns Hopkins. He also has a lot of experiences looking around, shopping, researching, having oversight in this space. So, very excited to have you here.
Thanks for having me, Charlene. I was really glad that we ran into each other so randomly at one of the conferences, and that's how we
Yes.
started talking. So, yeah, I look forward to having this conversation with you.
One thing that stood out to me was your experience in clinical AI and also just being a MD in ophthalmology. Let us know, how does that lead to where you are today?
Luckily, I came from a clinical background, and in my AI journey in healthcare, that really provided me with a lot of what I would think it's a different angles of consideration. And I'll give you a couple examples. I did most of my training in Johns Hopkins ophthalmology residency and then retinal surgery fellowship. So clinically, I take care of patients with problems in the back of the eye, including both surgical and non-surgical problems. So, for example, some of the conditions that I deal with all the time are diabetic retinopathy or age-related macular degeneration, and the standard of care for these conditions often requires repeated injections into the eyeball. Sounds like a terrible idea, but it's actually very effective. And on the surgical side, I take care of patients with conditions such as retinal detachment. So that's what I do on a regular basis. And then after my training, I stayed on as faculty at the Johns Hopkins School of Medicine. And I first got involved in AI research back in 2017 or so. That's when deep learning based image analysis really became more popular. So I had been doing that for a while. And then with the rise of GenAI, which has broader implication, my role at Johns Hopkins in the past few years has pivoted to more an implementation side of things, including the implementation of both clinical and operational AI tools. It's funny you asked me how my journey as a clinician informed my AI journey. I think one very specific example is revenue cycle management. And this is very relevant to retinal specialists. To put into context, when I'm in clinic on a given day, I see about 50 to 60 patients, and oftentimes about half of these patients end up needing some sort of injections for conditions such as diabetic retinopathy or wet AMD. These medications work very well in restoring vision and preventing vision loss, but at the same time, they're really quite costly. So if you use brand name medications for these conditions, each medication costs about $2,500, and it's really relevant to us as a practice because if the prior authorization is not done correctly, and we don't realize until our claims get denied, then the drug cost of $2,500 really then ends up falling onto the shoulders of doctors in retina practice. So I've seen this firsthand how painful it could be if revenue cycle management is not done well.
One of the most common pain point in eye center is the vision insurance and medical insurance.
Yes.
Most people struggle to bill both and they struggle with just denials across that. Do you see that as well? I mean, especially for the drug and other surgery practices.
So all the patients that I see are covered under the medical insurance because they have medical problems with the retina. So I don't really deal a lot with vision insurance per se. I do know that especially in a non-academic center setting where you have a mix of optometrists and ophthalmologists, from a practice perspective, it gets a little bit complicated trying to figure out vision, meaning glasses insurance versus the medical part. For me, I can dive a little bit deeper into the RCM issues I've seen.
Yeah.
Oftentimes, pretty much unless you're covered under Medicare. Definitely, if the patient has commercial insurance, oftentimes prior authorization is needed for these expensive intravitreal injections. So a lot of my staff members, what they do every time is go through my clinical schedule ahead of time. In fact, I have clinic tomorrow and I'm seeing 60 patients. So someone, as we speak right now, is physically going through my clinic list one by one and check each patient's prior authorization, whether they can or cannot get certain injections. So that takes a lot of time and effort. And as I mentioned earlier, since we do so many of these injections, even if you miss, let's say, 1% of it, there are very real financial implications for the retina practice.
Have you tried automating parts of it? Whether it's just the phone calling insurance, checking payer portal to verify it. I mean, every solution has like accuracy and all of that, but curious, what have you tried in the space?
So at Johns Hopkins, things are pretty centralized. So if you look at operations overall, about 10 years ago, most operations from call center to RCM, these processes were siloed and divvied up along different departments. So if we were having this conversation 10, 15 years ago, things were a lot more decentralized. A lot of these processes are centralized at Johns Hopkins now, such that we have a centralized call center, centralized RCM team. So what I do know at the health system level is that we have tried some automation strategies. For example, we had a pilot, and subsequently it did become a real program at Hopkins where we use GenAI for prior authorization. So essentially, it's a co-pilot approach where the biller would open. We use Epic on in one screen, and the payers portal in another screen. They log in, and then GenAI Copilot will understand the rules and regulations from the portal, and then pull the relevant medical necessity document from Epic. So we have done that as a pilot, and now we are using that, post pilot, but it's not across all service lines. And even though I myself is a big proponent of automation, at least at a health system level, for ophthalmology anyways, we're still pretty manual. That GenAI solution I mentioned has not extended to ophthalmology yet, and that has to do with the fact that decisions are made at a very centralized way. So we as ophthalmologists don't get to say, at least in a very easy fashion, say, hey, we want that, and we get to do it. It comes from literally the centralized RCM team.
I'm sure there's a lot of research going on at all times. Like, when do you look outside and when do you try to DIY?
I think that's an evolving field. AI governance, especially when it comes to integrated health systems, is getting more and more important and prominent. And this trend is evident in two different ways. You probably, over time, the past 12 months or so, I've seen a lot of announcements from different integrated health systems saying that they have now hired a chief AI officer. Some health systems, such as Hopkins, we don't have a single person, but we do have an AI governance team, and at Johns Hopkins called the AI oversight team. This is expected because as healthcare providers, including integrated health systems, start dealing with more and more AI vendors. The market right now is quite chaotic, so it makes sense to have more and more governance structure just to really govern the interaction between AI vendors and health system. So I think overall that's a good development for healthcare. And going back to your question of build versus buy, I think it's pretty system specific for a couple of reasons. I think culturally, for reasons that I don't completely understand, there is a cultural difference between integrated health systems. For whatever reason, some systems love to build more and the other ones want to buy more. So, very much a cultural thing. And also has to do with how integrated or ingrained that particular system is with a certain EHR provider. That's part history, part culture. Personally, culture and history aside, I myself, I'm a big proponent of buying because, and this is more coming from me putting on my researcher hat. Like, I understand how fast things are advancing in the field of AI. And even though there are a lot of really smart people, even in AI research and academia, a lot of these people are not trained to productize certain things, right? So just because you are very good at AI research and you have groundbreaking discovery and you publish papers and whatnot, I think that's a related but also very different skill set from productizing certain things. Have built a team and a culture from a company's perspective to rapidly iterate on things. And again, just because someone is very well versed in the fundamental development of AI doesn't mean that person has a team that does UI UX really well, right? So I
Yeah.
think, and then there's also like the customer success team, implementation, speed, all that. So for all these reasons, I think all else being equal, I'm a big fan of buying because there are companies, they're third party that move really fast and they're hyper focused in delivering products that work fast and well in a reasonable time frame. So
Speed is an interesting topic in healthcare. Most people assumed healthcare is slow, but actually, if we just look at AI script, right? Most Fortune 500 are not recording their corporate discussion team meetings. Healthcare are in many scenarios. So there is a lot of like things. I mean, there's a lot of reasons why they leapfrogged to the AI era with really good solutions and all of that. I'm curious, like, what have you seen either with Epic? I know that's where Hopkins is on, or outside of Epic, where you have working with either programs or pilots at scale.
you mean like examples of applications with good traction? That's
Yeah,
what you mean, right?
actually traction, like not just testing it out, but like the enterprise scale you mentioned.
To answer that question, I'll split it in two different buckets. One is the operational side, one is the clinical side.
Mm-hmm.
On the clinical side, we have seen most traction in two subspecialty. One is anything to do with radiology, because back in 2017 till 2018, when deep learning first came onto the scene, that's pre-large language models. Really, is the deep neural network that made significant improvement in terms of computer vision. So along the over the past few years, we have seen a lot of traction, adoption, and also approval by the FDA of radiology AI tools. And one example is stroke detection. Stroke is very time sensitive. You go to the emergency room with stroke-like symptoms. They scan your brain, and AI can say yes or no stroke, and literally every minute matters. Another subspecialty that has really benefited is in ophthalmology. So, for example, autonomous AI for diabetic retinopathy screening, which when it was cleared back in 2018 by the FDA, was the first ever autonomous AI system in any medical field that was approved by the FDA. So we really, as a field, we were part of history. And there was a relatively recent paper published in New England Journal of Medicine AI Journal shown that in real world deployment, diabetic retinopathy AI, that product is the second most commonly deployed clinical tool, and it's growing the fastest too. So that's the clinical bucket. When it comes to the operational bucket, I think there are three examples that really came to my mind. First one is ambient scribing, which you already talked about. Second one is in revenue cycle management, and there are different segments of it, which I assume we're going to talk a little bit more. And the third segment, which is a little bit less mature but catching up really quickly, is the voice category.
We talked about ambient scribing, voice AI. Let's start with rev cycle as well. Since rev cycle is a huge topic with many different subspecialties as well.
In the rev cycle space, in terms of strategy and business development, I see two ways to do it. One is which segment of the revenue cycle management you want to focus in, and also which segment of providers. And I think those decisions really matter. Broadly speaking, when it comes to the provider space, there are the outpatient folks and there are the integrated health system. And there's pros and cons. Integrated health systems in general move slower, but the contract size is probably bigger. And the reverse is true in outpatient space. And especially when it comes to the integrated health system and inpatient space, not only you have to deal with the pro fee, you also have to deal with the hospital charges side. And I think on a technical level, there's some difference in complexity when it comes to dealing with pro fee versus hospital fees. So I think as a company, one has to sort of decide what you want to focus in. And the other approach is think about which segment of the RCM to focus in. So there's the front end, mid cycle, and the back end. And broadly speaking, front end is prior authorization, E&B verification. Mid cycle is clinical documentation integrity and autonomous coding, and the back end is claims denial. I personally think each of these segments is really quite complicated, so it's hard to do well, at least in 2025, in all three instantaneously. So where I've seen traction is it's companies that do really well in one or two out of the three segment. So when you go to a potential customer and say, listen, like I'm really good at this one or two out of the three components RCM, and that's how I can bring you value. And once we work together for longer, I could expand or demonstrate value in the third segment as well. So that's what I've seen in the market. Yeah.
What's the standard of excellence? Like when people look at these tools, are they benchmarking mostly on retroactive data, or are they deploying this live and seeing if they are doing what their staff can do and minimize the workload?
I think there's enough consistency in data that if you in your pilot phase, if you benchmark your product using retrospective data, typically that's sort of the performance that you will see when you deploy it live post pilot. And honestly, you when you do the pilot, you probably need to do a little bit of fine tuning of the model anyway. So like day one
The
of pilots are a little bit
customizations, yeah.
customization is key. So no one's gonna come into a client and say, "I'm gonna do a pilot," and things were perfect, and then you deploy a week later. There's always some customization. So and that makes sense, right? Because as good of these tools are really good, but still, like the kind of patient profile and claims going in or out of different providers really do look quite different. And and broadly speaking, I think when it comes to the front end, which is prior authorization, you can look at benchmarks such as the time needed per PA to be filed, or on the biller level, number of PAs they can deal with before and after AI. Mid cycle will be the delta will be measured in terms of the charges that you can drop
Mm-hmm.
appropriately up billing essentially. CDI, I think it's a little bit more difficult, perhaps number of notes that did not require a human to go in and fix it later, something like that. And I think the backend, which is claims denial management, the KPI is relatively straightforward, which is X number of dollars got denied, you apply AI, you get back y number of dollars. Or you can also say of the 100 denials coming in, 80% of them can be completely automated in terms of managing them, like pre and post AI, that sort of thing.
Actually, on coding, so when you said automated screening for retina and also stroke, like I don't know if you know this, but like my very first paper in AI actually was for stroke, like just looking at like the working with
Oh,
radiologists. And I think
okay.
like that's why like these are two mature category where super urgent, tons of data, relatively output to see the result, right? I'm wondering if you have seen anything or have used AI coding in ophthalmology yet, or because like I would assume like that machine learning history may pave way to new innovations in ophthalmology sooner.
Less so in coding, and the reason is we are hyper specialized,
Mm.
and the number of CPT codes we build for, it's a very small subset. Like, especially for example, what I do, I probably build no more than 10 CPT codes in the clinic. Surgery, I add a few more. So that's a very easy task that you don't really need to automate. I think when we're talking about the mid cycle, the CDI and the autonomous coding, the use case is much more meaningful in inpatient because the patient stays in the hospital for 10 days. Many different kinds of doctors came and took care of the patient. It's that complexity where the CDI and autonomous coding really shine. A little bit less so in the outpatient, hyper specialized space like what I do, because we just don't. Our coding is very simple.
Yeah, and it sounds like even provider can master and know how to code well versus maybe a
Yeah, well,
hospitalist.
using Retina as an
Mm-hmm.
example, like especially in outpatient setting. So if we look across the three components RCM, I think what we really need help is prior authorization. It's very monotonous, high volume, and also claims denial. So the mid cycle is not as important. That's why I say like as a company, there are different strategies you can approach depending on what kind of clients you're dealing with. For Retina outpatient, it's the first and third component that matter most or like most painful. The middle one is relatively easy.
And then since things are moving really fast, we'd love to just take a step back and say, well, in 3 to 5 years, what do you think will happen in this space?
I think we will see continuous improvement and maturity in terms of adoption for the big three application in the operational space, which is ambient scribing, voice AI as the digital patient front door, and also RCM space. So I think these use cases are good. They will continue to be adopted, continue to be scaled, and there will be consolidation in the field. So that's the operational side. Clinically, I think the clinical application, there are a couple of things that get me really excited. One is sort of like an AI doctor, meaning these are multimodal foundation AI models that are specialty specific. About a month ago, a very big paper was published in Nature Medicine showing that if you pair a multimodal vision language model trained specifically for ophthalmology, you pair that model with an ophthalmologist, that combo outperformed a human ophthalmologist in many domains,
Mm.
in many clinical scenarios. And I think in the next 5 years, we'll keep seeing these papers, right? Like the AI um, cardiologist as a co-pilot, and you name it. As a society, what we need to figure out is like, what do we want to do with this? I think the FDA was never really set up. It was set up decades ago. It's not really set up for the Gen AI era, so it won't really know how to regulate like an AI co-pilot. So regulation is way behind innovation.
Yeah.
But clearly we see value add with this sort of setup. So I wonder, and I really don't have an answer for that, whether in the next few years we'll see different tiers of medical care. So if you can afford like the premium kind of medical insurance, then you get AI plus Alvin. If you're just a regular like medical insurance, you only get Alvin kind of thing. So like there'll be like here like differently depending on whether you put AI on it or not. And I think realistically, it's hard to charge patients or payers every single time you use AI as an add-on. Probably it will be all bundled somehow. So that's interesting and philosophically challenging question, but I think as a society we will have to deal with it sooner rather than later. The other area that's quite interesting to me, again on the clinical side, has to do with retina. So there's a field of study called oculomics. Essentially, is a study of the association between retinal biomarkers and systemic health. So now in 2025, it would combine really just common retinal images and deep learning. We can predict whether someone's at an elevated risk of having a heart attack in the next 5 years, whether someone has dementia or Alzheimer's or not. The third category is kidney disease.
Mm.
As you can imagine, the science is there. We have to figure out a business plan in terms of how to do it. Imagine you can imagine a world where in the not so distant future you can walk down the street, go to your local pharmacy or like supermarket and whatnot, get your retina scan, and within minutes you're told, hey, like you may be at an elevated risk of having a heart attack in the next 5 years. Go see a cardiologist. That really could close the care gap in many settings, especially in the more rural settings or in countries. I mean, in places in this country or even around the world where access to care is not that great. That can really reimagine how care is delivered on a population level for very chronic and costly diseases. So I think scientifically and clinically, those are two super interesting things that I'm paying attention to.
As and kind of like to wrap everything up, we talked about a lot of different fields. If there is one piece of advice you would share with other healthcare leaders, what would that be?
Meaning the buyers, so to speak. Like when you
Or
say health
folks
lead,
who
or just say
are folks who are on the fence, folks who are adopting. It can also be you can talk to the skeptics or the optimists in the field. Like, what would you say to them?
from a literally a very high level. I think the AI revolution is not any different from previous technological shifts. And broadly speaking, I think this will also hold true for AI, which is you can divide up the population into three buckets. The early adopter, the third, who are really going to adopt AI quickly and in a way that's meaningful. A third of people that, for whatever reason, no matter what you do, they will never adopt. And there's the middle third. I think as an organization or as someone like myself who really believe in the positive good that AI can do. And again, given within the context of limited time and limited resources, I think the battle is the middle third. So just keep thinking about the middle third. What can we do to build trust and implementation in the middle third of the population who you have a chance of convincing? So that's my advice.
Awesome. I think that's the place where people should spend energy on because the other two has made up their mind. Yeah. Well, Alvin, thank you for joining us at the Healthcare Intelligence Podcast. I'm sure we'll catch up very soon, and it's a pleasure to have you.
Thanks so much for having me, Charlene, and I really enjoyed our conversation.
Awesome.
Yeah.
I will pause recording.